Hello, everyone, and welcome back to another episode of AdvoKAYte, Holding Healthcare Accountable. This week, my guest is Dr. Robert Henderson. Many of you may know Dr. Henderson, who was portrayed by Alec Baldwin in the made-for-TV movie on Peacock about Dr. Death. But Dr. Henderson in real life is a gentleman, a scholar, and the kind of doctor you'd want taking care of you and your family. So we're going to take a deep dive in this episode into Dr. Henderson himself, the making of a surgeon. And it may not surprise you to know that we could have talked for hours and hours and hours and hours. So as it turns out, this is going to be part 1 of 2. So welcome to this part of the interview with Dr. Henderson, and we'll pick it up again next week to finish up that conversation. So thank you for joining. AdvoKAYte, Holding Healthcare Accountable. This podcast is my way of sharing what I've learned about the mistakes, the cover-ups, and the ways we can all protect ourselves. We're all in this together. Welcome to another episode of AdvoKAYte. I'm thrilled today to have my guest, Dr. Robert Henderson. We're going to continue talking about the Dr. Death case and particularly Dr. Henderson's role, his very important role in that case. The reason we're continuing to talk about Dr. Death throughout season 1 is because of the importance, because the issues that came to light in the Dr. Death cases are issues that existed prior to Christopher Duntsch and still exist today. So let me begin by welcoming our guest, Dr. Robert Henderson.
Good afternoon.
Thank you for joining us today.
My pleasure.
I want to begin by having you tell us a little bit about your background as a surgeon. I know most people think of you, they know you from the Peacock series and Alec Baldwin, who played you, but before all of this came about, you were a practicing spine surgeon.
Correct.
Will you tell us about your practice?
Correct. My practice was solo practice for the last 25 years of my practice, I think. I was in a group practice before that. But it was interesting. I was actually originally trained as a general and vascular surgeon and had started out in my practice in those fields and got into a partnership with another surgeon, and then he left after a year, and then I built that practice into a 5-man group. And but during that 5 years, I was being exposed to spine surgery by a physician that had moved into the office across the hall from me and had devoted his orthopedic spine practice completely to spine surgery. And then he asked me if there was a way that I could give him exposure to the anterior spine, both thoracic and lumbar, which is chest and abdomen, through the front. And so over the next several years, actually 5 years, I developed exposures to the front of the spine that worked very effectively and made a very safe, neat, efficient, quick approach to the anterior spine so that orthopedic and neurosurgical spine surgeons at the time could do what they needed to do, whether it was for tumors or whether it was for degenerative disease or trauma. Or just disfiguration like scoliosis. So then I came back to Dallas. I joined with that original surgeon into practice, and we grew that into a 5-6-man group over several years. And then I left to go into solo practice because practice of medicine was changing. And again, metaphorically speaking, it was a time in which they wanted to set up hospital insurance policies that were more inclusive and more group oriented, et cetera, et cetera. And they wanted to reduce revenue to the physicians. So the solution to that was to see more patients. Well, there's still only the same amount of time in the day, except in daylight saving time when you get an extra hour, I think. That doesn't seem to work out like that.
Right.
But I said that's not going to work with the type of practice I had, because what I was doing within that group practice was I evolved to where I wanted to see everybody's problem child, problem patient, the one they couldn't fix or the one they tried to fix and couldn't fix. I started doing that within the practice, and then I started doing that within my referrals too. In fact, my practice was built on send me the cases nobody else can fix or seem to be able to fix. And that's what I wanted to do, but I needed time to do that. So I went back to a private practice so I could have the time to spend with my patients. Mm-hmm. Not 10 minutes or 15 minutes, but an hour, hour and a half, 2 hours if it took that. So that's what my practice was like. And it made, most of my cases had one or a multitude of prior surgeries before they got to me. And so I also became very skilled in working in difficult environments. So I enjoyed that.
There's a few takeaways from where you found yourself at the time that you came to care for Mary Eford, one of Dr. Duntsch's patients, that I think mattered. First off, you were in private practice and you were calling your own shots. You weren't working for a big corporate group. You weren't working for a hospital. There wasn't anybody that I'm aware of who could put a gag order on you, so to speak. Is that right?
That's true.
The other thing that jumps out about it to me is that you were accustomed to seeing failed surgeries from good surgeons, bad surgeons, the gamut. So you were not, a native to being able to go in and see bad complications, right? So when you were called in to see Mary Eford, were you expecting just to see like another, well, this was a botched surgery and it's going to be bad, it's going to be a bad day, but I don't know how bad?
Yes, I wasn't intimidated to do that at all. In fact, I always just look forward to it as a challenge. I wasn't sure when they called me. They told me, I asked who's the surgeon, and they said it was Dr. Christopher Duntsch, and it kind of rang a bell to me, but it wasn't a loud one. But then when I got to the hospital, and this was on a Friday afternoon, and spoke to the administrator and the chief of surgery at that time about the case, they were both very upset about the situation. I realized that this was the doctor that I'd heard about a few months previously, had some terrible outcomes out in the Plano area. It turned out it was Baylor Plano Hospital at the time. And he'd had an outcome where he had operated on his friend and his employee and done a cervical surgery, a neck surgery. And the outcome was he was a quadriplegic and remained quadriplegic. And that he had also had a simple lumbar disc herniation. Lady who had expired postoperatively. And it turned out that was due to exsanguination or blood loss. In the recovery room or in the ICU is where she eventually succumbed, but it was just hours after the surgery. So now it all fit in. It was the same story that fit in. So I realized who it was. When I arrived at Dallas Medical Center, I met with the administrator, the chief of surgery. I spoke with them and asked if he had been, since they had informed him that he was no longer going to be taking care of his patient. And I said, well, have you informed him that he's lost his privileges? And before I took the case, I requested and demanded that his privileges be revoked prior to my taking over her case and operating on her. So they assured me that would happen. And it did happen. And so then I went in and looked at the diagnostics in the radiology department and was really astounded by what I saw on the x-rays. It was a little worse than what I had anticipated. The implant that he had proposed to put into the patient's spine was not in the spine. It was out to the side of the spine. It was in the muscles between the abdomen and the back. And then there was a screw that was appropriately placed in one of the vertebral bodies at L5. And then there was another screw that was just placed right through the spinal canal, right where the nerves run. So that was impressive. I couldn't operate on her the same day, which I would have preferred because her blood count was so low from the blood loss that she had suffered during the operation. Right. So she had not received any blood post-operatively over 2 days. And so I transfused her with a couple of units of blood to get her up into a safe margin for surgery that we did on Saturday morning. And as I reflected during that period of time, it was helpful because I thought about it and I said, well, obviously there's going to be some issues legal issues, malpractice issues arrive from this case, just from seeing the x-rays and from interviewing the patient, who literally had almost no motion in her lower extremities. And so I decided to record the surgical procedure, video record, which was obviously audio and video, and which turned out to have been a very prudent thing to do because it was helped further along when we came to trial 5 years later, I think it was. And because it obviated any argument that, recollections by the experts were accurate, et cetera, et cetera. Well, this was however many colors are in the video. Right. Documentation with audio, with a date and timestamp on it.
Picture's worth 100 words and a video is worth 100,000.
Yeah, exactly. So we did the surgery on Saturday morning. Got just cut through the skin, and immediately there was cerebral spinal fluid just flowing out of the wound.
Meaning that he had punctured into her spinal cord.
Yeah, it turned out he had torn the dura in 2 or 3 places and had not repaired that, made any attempt to repair that. And then as I explored further, and it was interesting because the cerebral spinal fluid was in there wasn't any blood. Cerebral spinal fluid kind of dissolves blood and washes it away and rinses everything. And so everything's pretty pristine. When you look in there, it's not stained with blood. So the videos turned out to be excellent as a result of that. And virtually anyone could differentiate between tissues. You didn't have to differentiate between shades of red and pink.
Mm-hmm.
So that was nice. We got in there, immediately saw the dural tears, saw the screw, the bottom screw on the right side, which was right through the spinal canal and going right through the S1 nerve root on the right. And it was kind of just floating. It wasn't hardly attached to anything. There was a rod that was connecting the two screws together, but the rod hadn't been secured into the screw above, so it was providing no support, no structural support at all, just kind of rattling around. The screw itself at L5, the upper screw, was in bone and was intact, and was interesting. On the left side, there were 3 or 4 screw holes that were not where they needed to be, not where they should have been, and which was the reason he made the hole and then pulled the screw out, because at least he realized it wasn't in those screws weren't in the right place. But then, as I explored further, there was a dural tear over on that side, and then there was a bunch of bone graft material, which was from the bone bank, and it's in a putty form. And I removed the putty, and it wasn't in an appropriate spot for it. It was in a spot called the foramen, which is the space between the 2 levels of the spine, which is where the nerve root comes out at each level. So I very carefully removed this putty-like material, granular putty-like material, and then I started looking for the nerve root, and there's no nerve root. There's no L5 nerve root. And then distally, I couldn't find it. And then I went up proximally where it comes out of the spinal canal or spinal sac. And I did find the blunted trunk of the L5 nerve root. So he had cut the nerve root in order to make room for the bone graft, which didn't belong there. There was also no evidence that he tried to enter into the disc space, which was the whole point of the operation, which was to take out the disc between the 2 bony vertebral bodies and place an implant. Well, he had never found the disc to remove it. So anyway, it was really grossly inadequate surgery. And I think multiple times during the recording, I said, because I had read his operative report previously. His operative report was pristine. It was detailed, pristine, orderly, and appropriate, very correct for every step. And so it was not that at least mentally he didn't know how to do the procedure. He certainly didn't know how to do it with his hands. And I stated it was like he took every step of the procedure and did it wrong.
I think that's a really important point because, you spine surgeons, you have a formula and a way of dictating your operative reports, and there are things that you're dictating because they're important, and detailing the procedure, any complications that you encountered, things of that nature. So the disconnect between the way he dictated the way the surgery should have been done, it was like you're saying, he knew this is the way the surgery should proceed. I'm going to verbally dictate through, this is exactly how to perform this surgery. But the actual surgery itself seemed like either somebody else performed it or he was not cognitively able to understand what he was doing. He wasn't physically able to do it. What did you make of that just complete disconnect?
Well, it was interesting as you were just discussing the facts. it made me think of, well, it was almost as if, because he was bright and he was intelligent, and he was informed with his dictation, but the way he performed it was almost as if he was blind, or had a blindfold on, because I wouldn't want to. I'm not meaning to disrespect what blind people can do. They have tremendous senses and probably would have done the procedure 10 times, 100 times better than he did.
Yeah.
Which I'm not really joking about.
Right. I know.
Probably could have. That's how bad his surgery was. So I started thinking, well, it occurred to me, well, maybe he's an imposter. Maybe he has manipulated himself in this situation without ever having been formally trained. So on Monday, I started investigating, and I called his residency program and I called his fellowship program. And either immediately or within a few days, I was able to talk to that director and that mentor.
Well, I know that was a treat for me, and I can't wait for you to hear the rest of our conversation where Dr. Henderson really digs into what caused him to launch his own investigation of Christopher Duntsch and the effect that that had on taking him out of circulation for other patients. So thank you again for joining. Don't forget to like and subscribe and come back next week.